Hello to everyone joining remotely. Welcome to the GRIT seminar series. We're waiting just a few minutes for folks to join the in-person and virtually. Thank you. Hello, everyone. My name is Grace Thomas, and I'm the administrative assistant here at the research program on children and adversity. It's so exciting to see those who are joined in person, as well as all of you joining remotely. And thank you for joining today's Grant and Sponsored Research Initiative Seminar, or GRIT for short. The GRIT seminar is designed to increase a regional knowledge base and capacity for implementation research, build a stronger mutual learning network, and provide training and learning opportunities for partners aligned with our training grant objectives. All right, and thank you again for joining, and please make sure to stay tuned on our listservs for upcoming sessions in this year in 2025. Our next session will be with Dr. Theory, our Chief Fellow at the end of May, and that is to be announced. All right, and before we get started, I wanted to highlight that our lab is currently hiring for the Associate Director for Research. This role is vital to overseeing research operations and the ongoing development of the RPCA. It is an essential part of both our current and future research initiatives and contributes to the Boston College's broader mission of expanding its global research footprint. Interested candidates can apply on Boston College Careers webpage. All right, and now on for today's seminar, we are thrilled to be joined by educator and child advocate Ernest Masaaba and Becky Ramsing, Senior Program Officer at the Center for Livable Future at Johns Hopkins Bloomberg School of Public Health and Vice Chair of the Board of Directors for Operation One. Their talk, Bridging Borders, Global Health Education and Child Sponsorship in Uganda, will highlight the incredible work being done at AOET Uganda. Please welcome everyone and joining Ernest Masaaba and Becky Ramsing. All right. Closer to us. Yes. The technical difficulties.
No worries. Great. So I'm gonna start off and then pass it to my esteemed colleague Ernest Masaaba. So we are going to be talking about global health education and child sponsorship in Uganda. How are we doing? Okay.
Sure. I'm so sorry.
Oh, okay. Let's share. A moment. Oh, excellent. Okay, there we are. All right. Grace introduced us. I can just say a little bit more about myself, and then when Ernest can share more about his journey and his work that he does. Professionally, I'm a dietitian with a long career in nutrition and public health. I actually began right down the street at Brigham and Women's Hospital, where I did my dietetic internship many years ago, and then worked clinically for several years. My current job is at the Johns Hopkins Center for a Livable Future. We're an academic center in the Bloomberg School of Public Health, and we work at the intersections of food systems and public health. So over my career, I've been able to live and work globally with focuses on diabetes education, women in agriculture and nutrition, community health, and food systems training. But most importantly, I lived and worked with AOET Uganda in 2008 and 2009 and have continued to volunteer with them through Operation One, which I'll explain who that is. I've served on the board since 2016 and lead our partnership with our AOET Health Center. Just a little bit of background about how this all connects. You'll hear different terms. You'll hear AOET, you'll hear Operation One. This is an image we just use to describe how we work in partnership with AOET at Operation One from the bottom up. So on the bottom, AOET Uganda was started in the mid-90s by a Ugandan for Ugandans to address the ongoing and crucial needs of orphans and vulnerable families as a result of the HIV/AIDS crisis. AOET stands for AIDS Orphan Education Trust. Operation One, which is actually formerly called AOET USA, was founded to connect donors and resources to the work of AOET. Our current mission is to engage supporters and acquire financial resources in order to provide education, training, healthcare, and spiritual development to vulnerable children and families. And we rely heavily on partners and donors to help here in the US to engage and support our work. Okay, and our current initiatives that we have at Operation One that you might see about how to include child sponsorship, like a one-to-one child sponsorship, education support, supporting AOET's health clinic. We send service teams, and we have other initiatives through the years, from empowerment to clean water projects. Okay, so you may ask why Uganda, and we can talk. I'm gonna spend just a few minutes talking about Uganda and some background about on Uganda, and that really highlight the importance of the work that AOET does. Uganda faces high poverty rates, limited access to quality education and healthcare, and a rapidly growing population. And we feel that investing in these sectors addresses critical challenges like disease, illiteracy, and youth unemployment, helping break the cycle of poverty and enabling sustainable national progress. This is just a timeline. I won't go through it of Uganda's history only since 1894, but Uganda was around a long time before then. But really in the last 100 years or more has had quite a up and down history, with the colonial era and independence only in 1962, followed quickly by the Idi Amin regime, where marked with political instability and widespread human rights abuses. And then on the heels of that came some civil wars and the HIV/AIDS crisis. Only in the last few years in modern Uganda, Uganda is thriving, and in many ways, but in other ways struggling with challenges of a growing country with population growth and increase, but also has increasing economic and political challenges. It's all one thing key about Uganda. It's one of the youngest populations in the world. So 73% of the population is actually under 30 years old. Only 40%, over 40% is under 15. And the median age in Uganda is just shy of 17 years. This youthful demographic presents both a significant opportunity and challenge. One thing key is, as youth come into their adult years, there are few job opportunities and high rates of unemployment, which make it challenging for them to enter the workforce and thrive. Just a few, pointing out a few realities of just poverty in Uganda, particularly on children. We'll really focus down in our conversation about children. There's especially in the rural areas of Uganda, which 83% live. There are challenges and just with infrastructures, with attaining electricity and running water. Many of them are peasants, farmers. 40% of Ugandans live on less than $2 a day, and there's high rates of malnutrition and children under 5. Family structures are an opportunity, but also a challenge. The average family size is 5.2 children per woman, compared to here in the US, we're at 1.7. Many children are orphans because of the HIV/AIDS crisis, but also other disease and conflict. Many of the families are polygamous, adding challenge. And in those families, girls are really valued for dowry. So having more children and more girls is seen as a benefit. But education is really seen as key for getting out of poverty, but there are many barriers. But thankfully in Uganda, they have university primary education, That began in 1997, but there are added fees involved and especially for uniforms, lunches, and that blocks access for many kids. So even though their tuition is paid, they can't make it to the school every day. The pupil-teacher ratio is very high. It's 43.1 compared to, we have 16.1 here in the US, which results in crowded classrooms. Also a lack of materials. There's one textbook for every 6 students on average. I think it's lower than that. And many of the classrooms are not conducive for learning, with dirt floors, crowded benches, broken windows, and the education is exam based. Anything else on that I should add, Ernest?
No, I think that is it.
Okay. He's the expert. I'm just giving an introduction. So the outcomes of this challenges with education is, although literacy rates are higher, particularly in the urban areas and rural areas, they can be down to 25% and literacy rates. Primary school completion is about 51%. So most kids will start primary school, but many will drop out. And then even fewer go to secondary school. The enrollment for secondary school is about 27%. And in that, about 30% will drop out before it ends. And less than 7% of the students will move on to university or other tertiary education. One other challenge is in Uganda is just health. AOET runs a clinic. You're gonna hear more about it from Ernest, but there's many challenges in healthcare. One is just the HIV, ongoing impacts of HIV with AIDS, which is still impacting families and children. There's a lot of needs in the community health needs. Not only NCDs and hypertension, but also respiratory diseases, malaria, and other and diarrheal diseases that are common. Many hospitals and clinics struggle with poor infrastructure and low access to health facilities. They have to walk a long way or try to get transport to the health facilities. And in many of the services, they don't have funds for covering many of the services or the materials like the lab, the reagents and the microscopes and the medications. Anything on that one that you can add?
Yeah, of course, there are a number of challenges that we have towards health, but of course, these ones that we have pointed out are the major ones.
Okay.
Otherwise, there are many.
There are many. Yeah. One big challenge is the number of doctors. We found this is really compelling. And the ratio of doctors to patients in Uganda is 1 to 25,000. WHO recommends 1 to 1,000. So they have a little ways to get there. So I just want to point out before you step, but just I know this is, you work in with children and adverse children who deal with adversity, and I think there's unique challenges for girls, but also for boys in Uganda. For girls, there are many girls have higher rates of dropouts for many different reasons, be it menstrual or pregnancy or being needed at home. 24% of young girls have early pregnancies, especially in the rural areas. There's a pressure for early marriages. There's high issues of sexual violence, many single parent households, and gender bias against girls. For boys, there's also challenges. Boys have a much higher rate of drug use. They get pulled into child labor, also are impacted by domestic violence. They have limited access to employment, and they are influenced by traditional gender roles, which we can talk about more. And I would just say, thinking about, working with children and families and development, Uganda is really a strategic location. It's surrounded by many different countries, Rwanda, DRC, Kenya, South Sudan. It has a young population, but it also has generally good governance and educated youth. So it could be a leader. There's many potentials for Uganda because of where it sits, and it's fairly stable political situation at this point. But there are challenges for that as well. So the vision really in how when we are working with Uganda, is imagining Uganda leading Africa with more technology, agriculture, and democracy. So I'm going to pass it now to Ernest, and he can talk a little bit about AOET, which is a program in Uganda that really addresses a lot of issues that I introduced.
All right, thank you so much, Becky, for giving a whole picture about Uganda. Once again, I'm Ernest, and Ernest is an educator in Uganda and currently working with AOET Uganda as the country programs director. And I've worked with this organization for the last 17 years. So, who is AOET Uganda? AOET stands for AIDS Orphan Education Trust Uganda. And AOET was established in 1995 after recognizing a need for urgent action in supporting children, families, and communities who were affected by HIV/AIDS and other health-related illnesses. Just like Beck gave the brief background about Uganda, what you can realize is Uganda has three major problems. We have one of the major problems is poverty, then the second one is ignorance, and the other one is disease. So you find that in the early 1980s, because of ignorance, people did not know how HIV/AIDS was being spread. And given the background that Beck has just given, Uganda is polygamous, and we also have a culture of wife inheritance. So you find that people died in large numbers because of polygamy. People died in large numbers because of wife inheritance, leaving behind the children. So in 1995, here comes a Ugandan establishing AOET Uganda. So we are a non-profit and child-centered Christian organization operating in Jinja. Jinja is one of the districts in Uganda, in eastern Uganda. So it was not until the year 2000 when AOET was officially registered and recognized by the government of Uganda. Our current programs include, we have the child welfare program. We look at sponsorships of children. We are working with the Operation One, getting a sponsor attached to a child in Uganda, and this sponsor keeps on sending money on a monthly basis to Uganda. So we have child welfare coordinating that, bring children on the program. How do we get these children on the program for sponsorship? We do partner with churches. We do partner with the leaders in the community where we are. And also we have schools where these children come and then are identified. And then we have a health center where their guardians and their parents come, and then we identify them. So through the partnerships that we have with the churches, the schools, the community, and then our health center, we identify a vulnerable child and then send over a profile to Operation One, and then Operation One finds a sponsor for this child. Then AOET has schools. We have two primary schools, what you call the elementary schools, and then we have one secondary school. And in our schools, we have 1,250 children coming over. They are integrated schools. AOET, remember in the beginning, I told you we are focusing on the orphan and vulnerable child. But again, in our schools, we are not focusing on only the orphans and vulnerable children. We have integrated them because we do not want to create stigma. So we have 60% of children coming to our schools, orphans and vulnerable, and then 40% are coming from average families in Uganda. So they integrate, share stories, and then we don't have the other children being stigmatized. Then we have a health clinic. The health clinic provides medication to our children, both the sponsored children and the other children who come to our schools, and I've told you 1,250. And then it also offers medications to the community. We have medical mobile outreaches, and we also have a lot that is done at our center. Like at a health center, we have deliveries, that is maternal child health. We have deliveries, we have antenatal care, postnatal care. We do safe male circumcision, and safe male circumcision, it has been found that when a male is circumcised, it reduces the HIV, it reduces the chances of getting the HIV by about 60%. So the government of Uganda is encouraging most males to undergo safe male circumcision, and our health center carries out safe male circumcision without charging the community. It is free of charge. The males walk in, they go through the counseling, and then they eventually they go under the operation of circumcision. So we also do mobile clinics, and then go out in the community, offer free medication to the communities where our children come from, and then far away communities that cannot access health care. In Uganda, of course, it's rare to find someone who is on medical insurance. So where most people are doing self-medication, and it is estimated that 1 out of 2 Ugandans self-medicate themselves, simply because health care is very expensive. So people tend to, like, if I have a brother and was sick yesterday, has healed and left over medication, I can also just take over from there, the medication that he took the other time, without going through a system. Of course, that is dangerous, but that is mostly done. And our community, our health center tries to go into the community and then help out with this. We also do HIV/AIDS care. We have over 500 HIV patients coming to our health center, and then going through the whole system of care and getting antiviral drugs, being monitored on the CD4 counts. So there's a lot that is being done there. So we also have empowerment projects. AOET looks at a whole child. We do not just take this child to school, but we do, of course, we have schools that provide education. We have health clinic that provides medication. Then we have empowerment projects. These are skills that are passed on to the caregivers. Of course, after the child coming to us, if they go back into to their homes, what are they going to find? So we are looking at empowering the caregivers so that they can be able to take care of this orphan and vulnerable child. So the skills that are done in empowerment, we have rearing of piggery, poultry, then we have welding, training, tailoring, hairdressing, mobile phone repair. So they choose from the variety of programs that we have in empowerment, and then they train in that. And after training, we group them. For example, we recently had about 20 women trained in tailoring. And what we do is we group them after learning a skill, that is after 3 months, learning a skill, then we group them and then give them a startup kit. So like if they are 20, we group them in about 5, and then give about 5 sewing machines to that group. So that group goes into the community, at least find something to do, and then they help themselves. They can buy a second sewing machine, and eventually all the 4 or 5 in a group get a sewing machine, and then they use it in their homes to take care of these vulnerable children. Then we have a children's village. In the children's village, again, we do not have an orphanage, but this is a foster care children's village. What do? We have 24 homes in this village. And what we do is we look out and enter into a memorandum of understanding with a family that is willing to take care of more children, more foster children in addition to their biological, but is limited by space. So we do get these through the churches that we partner with. So the pastors, the church leaders identify to us these families, and then they go through a process until we enter a memorandum of understanding with them to take care of additional at least 4 children, but one at a time, such that we do not want to always overwhelm them. So what we do as AOET in this MOU is we provide accommodation. We also provide gardens where they can grow crops, and we also take on their biological children and sponsor them. They go through our sponsorship program. Then we also give them an additional child after every year. So the purpose of doing this is for this child, this vulnerable child, to grow up with someone to look up to as a mother and then as a father, not growing just in an orphanage and then getting out and all that. So these families take on these children, and then we ensure that one of the people, I mean the couple, is working. We do not bring in all those that are going to depend on us. So we assume that the money that these people would have spent on rent is saved. And then, of course, we teach them skills, we teach them business skills and all that, how to save and everything that is involved. So you find that because they are not paying fees, we are paying for their children. They are not buying food. We have given them a garden where to grow crops. They are not paying rent. We have given them accommodation. They save this money. And after a period of 5 years, they are supposed to integrate back into the community. They buy a piece of land, build a small house, and go with all the children that we have given them. But AOET continues to support all those children, both biological and foster, through school. So that is the model that we have. We have success stories, and of course, as Ugandans, we also have failures as such. But we have registered more success through this, and many people are coming to learn from our model. Then we have the LEADER program. The LEADER program, LEADER is a district north in Uganda. It was so much affected by war for over a period of 20 years. The Lord Resistance Army, the rebels, of course, devastated the place, and people lived in internally displaced camps. So you find that because of that, AOET went in there to resettle and then provide education and skills to the children that had gone through trauma for a period of 20 years. So we have a school in Lira, a primary school, with over 400 children coming through, and we have done great there.
You want to pass that?
Yeah, that is our vision, mission, and then organization values.
Oh, this is, so why does this matter? AOET's model of sponsored children, there has been several studies that have been looked at children who are sponsored in this model, and they do find that children who have the sponsorship are 2 to 3 times more likely to stay in school, to avoid child marriage, and to access health care. I remember I've had the privilege of talking to families who've had children sponsored, and just the just knowing that their kids will be in school every day and not have to drop out because of fees, and that the parents can use the small money they earn for food and supporting the family, and not having to chase around to find the school fees, is just a huge burden lifted from these families, and really helps the families thrive. There's also a long-term national impact. It can boost future income by 20 to 40% as more youth are educated and ready to enter the workforce. And studies show that communities with higher education access actually see lower fertility rates, higher economic growth, and more stable political participation. Here's a study here from 2013 showing that sponsorship has a large longer-term economic effect than any other intervention, like direct food aid or cash. It's a challenging model, but there are certainly some huge benefits from that. Do you want to talk about that, or should?
Yeah, so AOET is child-centered, and of course, in our approach, we do raise a whole child. And of course, we look at the needs, the physical, social, intellectual, academic, psychological, spiritual, and environmental, and the services that I've just mentioned. There's nutrition and health, there's family and community, there's education, psychosocial support. We have a chaplain, and then we have a safe, secure housing. So we are child-centered, and we have a holistic child program.
Yeah. So the next few slides, Ernest has covered most of it, but with just a little snapshot on some of the services that really impact the child welfare. So I don't know if I can go through quickly and you can just, any other, you want to comment on our child welfare staff?
Yeah, we have 5 full-time social workers at the child welfare program. We have a total, AOET has a total of 128 staff, because we are in different departments supporting this child. There are those that are in health, there are those that are in child welfare, there are those that are in the schools. So in total, we are 128, but here, zeroing on child welfare, they are full-time social workers. And these ones do home and school visits. They visit different homes of these children. Right now, our program has over 800 children sponsored through kindergarten to university. So these 5 full-time social workers, I know the ratio is big, but that is Uganda. Yeah, we can do it. And they do home visits, they do school visits of where these children come from. Like recently, they did home visits and realized that most of our children were falling sick because of malaria. And we gave out mosquito nets. And luckily enough, the government of Uganda has introduced a malaria vaccine. You get 4 shots, 1 at a time at different intervals. So we assume that by giving out mosquito nets and children sleeping under mosquito nets and getting these malaria vaccines, malaria is going to reduce so much in Uganda. Then there's also family support. They connect to services, sponsor. They do sponsor updates and communication. Then we also have a chaplain. The one smiling, the gentleman smiling is the chaplain, and he does a lot of work with our children.
Talked about education, most of this.
Yeah, this is covered.
Yeah, it's and also up to university as well, they support. I didn't put that in. Here's some pictures of the children's village. Anything else you want to say here? This is one of the houses.
Yeah, the houses are self-contained. We have electricity in them, and then we have water flowing. This is the health center. And what they do is what you see in the picture, they are doing immunizations. And we always have so many children being brought on these days. We immunize against measles, polio, whooping cough, and many other diseases now, including malaria.
And one thing more recently, just when the coming out of COVID and where the young youth pregnancy rate was much higher, they were able to really focus on really training some of these young mothers to love and care for their children. So they were able to identify that through the women coming in for immunizations and maternal and child health. So the staff is really innovative and coming up with solutions and ways to reach these young women. Anything on empowerment?
Yeah, vocational skills I've talked about.
Yeah, I talked about that. Okay, sorry. Oh, this is it. So one thing, as you mentioned, that we focus on partnership, not necessarily on serving, but really on partnership. And let me get my notes here. Sorry. We see three really key benefits of partnering with an organization. It ensures efficient and impactful use of resources, and we really have found the dollar can stretch. A dollar toward healthcare or any service stretches much farther in Uganda than it would even here in the United States. We also find the partnership really really helps with mutual encouragement and alignment. So by meeting, just sharing support and validation of each other and the work that they're doing. By meeting with the teams, we meet monthly with the health center team, and our director meets with the child welfare team regularly. We learn from each other, and their work is validated and confirmed by us, because this means a lot when they're working day to day in difficult conditions with very little immediate results or rewards for someone. So someone just saying, we really appreciate what you're doing goes a long way. And I think, and this is really relevant now, just more reliable and steady funding and collaboration that happens with partnerships, especially private partnerships, especially with the current upheaval of USAID and international fundings. This health clinic and the services that AOET provides is really filling a gap. And it's operating when many other clinics have actually had to close, and they've remained open because they have private funding. So these partnerships and funding models are more reliable and consistent really in these turbulent times. Do you want to talk about this or? Okay, if you want to get involved, there's a lot you can do. There's a QR code here. And we have some, for those of you here in person, we do have through Operation One, you can have this one-to-one sponsorship model if you want to join, but there's also other ways to give if that's not your, if you're not able to do that at this point. You could advocate even here for policies that increase foreign aid and focus on education and health. You can support small nonprofits like Operation One or other ones that are doing this. There's many that are doing this kind of work. And that's so important. You can just talk about Uganda and just international work in your circles and really support, look at the businesses that you support that can empower these East African entrepreneurs. We just really feel like at Operation One, we really talk about the power of one. You don't have to change the whole world overnight, but you can start with one child, one classroom, one future. So I think I just have opportunities for questions, and that's it. Yeah. Yes.
So 75% of the population is under 30. Why is that? What happened to the 31 and over?
Yeah, given the background of Uganda, many people died. The older people died in the early 1980s due to HIV/AIDS, leaving behind the young ones. And you find that Uganda is one of the countries in Africa that has a high birth fertility rate. So many girls get married at the age of 15. So you find that you marry at the age of 15, by the time you reach menopause and you're not on family planning, you have 10 children. So it's the reason as to why we have many young ones. And our life expectancy is not long. Our life expectancy is 65 for a man. And yeah, after that, you are living on borrowed years. So, so the life expectancy is also short.
Ernest's father, who's what, 94 now?
Yeah.
I have a question.
Speak into the microphone. I appreciated, the data and study you shared that highlight the outcomes for child sponsorship, and it was particularly interesting to hear about, the skills development and the empowerment program. I'm curious, Ernest or Becky, if you could, talk a little bit about a particular child or family whose story really embraces or showcases that success.
Story?
Struggle for
like a one particular story.
That showed success.
Yeah.
Okay. Yeah. In fact, there are quite a number of stories. We have children that have graduated, and we have engineers, we have doctors, we have teachers, all sorts have qualified and went through, of course, AOET Uganda. And one of the success stories that we have, a story that I told recently was there's a child who was being sponsored by AOET, and this child here reached a higher class. When they reach higher classes, they have to go in boarding school. We, like Becky shared and said, our education system is examination based. So you find that when a child reaches primary 7, that is the highest class in a primary at primary level, they sit for a national exam. And this is this national exam to make them, if they pass, to go to another level. When they reach senior 4, again, they sit for another national exam. When they reach senior 6, they sit for another national exam. So because of competition, it's not only about the child passing going to another, but in Uganda, when a school performs well, that is when you can get either more children, you can be famous and all that, because it's put all over media, how you performed and which school performed the best and which school performed the worst. And of course, you cannot afford to be among the best performers. So this is a child who was sponsored through AOET. And when they reach higher, I mean, they come to a boarding section. It's a bit of, the fees is a bit higher. That is not paid by the sponsors. So we ask their parents to at least pay an additional amount to what they pay in this section. He as a child, we always give notices and then say, on this date, you are supposed to be paying this additional amount because your sponsor has paid this. So this reaches the timeline and the deadline for payment. This child has not paid. And then I call this child to my office and then tell them, please, can you please go back home? And then because your mother has not responded, we have not heard from her, go and bring this additional amount. We need it. This child goes home 1-2 days and then gets the mother's mobile phone and writes to me a message. I say, dear sir, because they address us as sir. I say, dear sir, I would like to be a nurse, but you are killing my dream by sending me home. Full stop. I read this message and it hit me hard. I thought, all along, I thought I was a child advocate. I'm supposed to leave this child too. But he has gone back home. What I did, I got on the phone, called the mom, and then asked the mom to come with the girl to school. When they came to my office, everyone started crying and crying. I told them, no, do not cry. I called the other administrators and we determined and told them, please, she's called Goretti. Please leave Goretti to study. Never send her back home for anything. So we gave her a bursary in addition to the sponsorship she has. And right now, when they sat for the national exams, Goretti brought the best grade and was one of our best performers. She went to a nursing school. She's a nurse. She has come back. He's supporting the poor mother. They are no longer in the same condition that they were in. He's supporting the community. And yeah. So many like that happen.
Wow, thank you.
But that was so much touching to me. And then I'm like, I thought I was a child advocate, but again, I'm sent back this child. And this child realizes and say, you are killing my dream. I said, no, I'm not a mother of dreams. Please come back and study. Yeah.
Ernest, I would say you're a child advocate. Another story is one of the child welfare employees, Priscilla. She was a sponsored child. And now she's helping those kids that are getting sponsored. And I actually sponsor her daughter. So it's like full circle for her. And she is probably one of the most dedicated child welfare workers there. There's a few of them that came through the sponsorship program. Priscilla, Dowdy, Shamina, they all know what it's like to be these kids. So they put their best foot forward every day to help them get sponsored and do what they can. And they know all the kids by name, birthday. It's incredible to see. But Ernest advocates for every one of his employees. And I didn't even know Priscilla's daughter needed to get sponsored until Ernest brought me into the conversation. So it's one of those, every kid means something to them there, which is very cool.
Excellent. Thank you so much. I'll take a look at the Q&A to see if there's any questions. Teresa, I see you have your hand raised, so I'll unmute you.
Hi, yeah, I wanted to thank the presenters for all of this great information, and it's such a wonderful program. I had the honor to work in Gulu, northern Uganda in 2004, 2005. And at that time, we were studying group interpersonal therapy as an intervention for the children affected by the war in northern Uganda and looking at depression as an outcome. And because of the published research that was in peer-reviewed journals, there was a finding that the War Child Holland psychosocial program, as much as they thought it was doing things for mental health, the effects were not there when it came to mental health outcomes, but they were there when you used an evidence-based mental health program. They probably, had they measured things like self-confidence or self-efficacy, there could have been outcomes, but that was not what the trial was focused on. It was focused on depression. And so I just want to bring forth this idea of publishing in the peer-reviewed literature elements of your model that you can help contribute to the evidence base. I find your fostering program really intriguing because of the housing element as an incentive for families. And I'm wondering if you've studied that using a rigorous design that could be published in the peer review literature.
Oh my goodness, as a fellow academic, I would love to get a student there for, a grad student there for 6 months to do some of that data collection, and even some of the outcomes of, like what tracking down, it's a fairly, young organization, so it wouldn't be hard to track down the students who have come through the program and just get some numbers. But yeah, definitely, the program up in Lyra, and Ernest didn't speak too much to it, but it has some really great, the leader there has some really great novel ways of working with them, and but maybe not novel, but innovative. And I think that could be a really good, and she has done some trauma-informed care there through another organization that had some materials. So I think it's an excellent idea. Yeah, I think this study.
Yeah, I think it just behooves us all when we think we've got something innovative and exciting to push it to the next level, to
Yeah.
really learn if it's evidence-based. And if there is evidence, that really puts you in a great position for further funding, working with the government on scaling it. So it seems that you have very sophisticated models, but it might be time to start thinking about partnerships like you described, but also with academics. And we work with Fred Semawala, who has a longstanding relationship in, I think it's University of Makerere, and several other universities in Uganda, but striking up some of those academic partnerships so you can get rigorous evaluation of some of your great models would, I think, be really super. And we have a training program in implementation science and mental health services research called Achieve. It's a D43 funded by the National Institutes of Mental Health. We're recruiting right now at the PhD level for people who want to work in our countries, which are Rwanda, Sierra Leone, but also Uganda is in the partnership under Dr. Fred. So you might want to network a little bit with that group, because there's some PhD level Ugandan researchers who've been trained by that program, or people who are applying to the program who might want to evaluate a promising model like your foster care home situation. And it could be another way to just solidify your base for funding and further scale to have that evidence.
That's excellent. Yes. And I think some of these smaller national organizations, small, like NGOs, don't get as much attention as ones that have been a USAID organization, or internationally funded and started. And this one, there's no Americans on staff, so it often gets looked over by the international community. But the model,
But published peer review journal articles can change that, is what I'm saying.
100%. I agree. Yeah.
So those partnerships with academics, and you've got such strong academics in Uganda, we're training some of them. We've had people throughout the years apply to adapt some of our Rwanda evidence-based models to Uganda. So Rachel and Grace could help you meet some of the talented Ugandans we've gotten to know, and right? I don't know if Dr. Tiedi has the chance to chat with you, but you've got talented Rwandans who, Uganda, Rwanda is a very easy research collaboration. So, networking at that level would be really exciting, I think.
One of the health center staff is just finishing up, or has she finished? Patricia, she was doing her MPH at Macquarie at University.
I think she's not yet.
She's not yet done, and she had some research. She was the one that was really spearheading a lot of the mother-child training, and so that there's a lot of really smart, intelligent people that work there that could partner.
Yeah, publish. Get it published.
Thank you.
Thank you.
Yes, Dr. Theory has a question.
So thank you for the work you are doing in Uganda. I sometimes travel to Uganda and some of the places you were describing, but under the HIV programs, not in the areas of child care. But the model you are using, particularly in matters related to foster care, is really amazing. For us in Rwanda, though we are trying, I think we haven't reached it to your level, and probably that there might be a chance to learn from you for the people who are interested in social care and child welfare in the National Commission of Children's issues in Rwanda. So you've described how you recruit children into foster families. I just want to know, do you recruit children who are affected by HIV or of the families affected by the HIV? That's the question number one. And question number two, at what age do people or children in foster care transition from foster care to go to live on their own? And then are there mechanisms to follow up their lives when they transition from foster care to the next stages of their lives? And then if mechanisms are there, what challenges, what successes? Thank you.
I think, hope I remember all the questions. Number one was, do we take in only children with HIV or those, we take in both children who are affected and affected by HIV/AIDS. It's the reason why I told you our schools are integrated and we do not want to create stigma. Some of the children are living with HIV/AIDS. And some of the children are just affected because their parents passed on because of HIV/AIDS. So we take in both. Then question number two was, at what age do we take in these children to the foster care? What I want to let you know is we do not take in, or not all our sponsored children are in the foster care. Other children that we support, because I told you we have over 800 right now on the program being sponsored, but they come from their homes, a majority. In our children's village, we have just slightly above 100 children out of the 800. So we have just above 100. And yeah, in foster care. And in foster care, we consider those that are homeless. Like most of them that we have, both parents passed on and they are living either with the elder brother who is also not working, or a very old woman who is the grandparent who cannot support them through school and then provide better essential needs. So we take we take in those at the young age, those below the age from about 3 years to the age of about 10. Those are easy to handle and then to groom than taking in an adult who is already.
And then when do they exit foster care on the other side?
When
do they exit foster care at the age 18 or any age?
No,
just-
after 18, you're not considered a child in Uganda. So anyone above 18 is not a child. It's we
That's
take
when
in.
they transition, right?
No, when like during transition, it's like when we sign this MOU, this family is supposed to stay in our children's village for a period of 5 years. So the 5 years, you have your biological and your own. Then after 5 years, when you buy a piece of land and then build your own house, you move with all the children, biological and foster. Then AOET continues to support the children through school. It continues monitoring you. How are you doing? Where are you finding challenge? Where are you finding challenges? How can we help? And then it's like when they're adults, that's when they can leave the family and then go and start either living on their own. Yeah, so we ensure that at least they go through that process and then until they become adults. And then what are the challenges? Some of the challenges are we have had a few families reach the time of transitioning back into the community, and they have just bought a piece of land and they have not built. They're asking for money from AOET again to build for them houses, and we do not have that. Then we have challenges with they have bought a piece of land, they have built, but again, when time comes for them to go into the community, they hand over the foster children. We cannot go with their children. We are going alone.
Mhm.
Yeah, so those are some of the challenges.
Thank you.
Yeah.
Thank you. All right, I see we have about a couple minutes remaining for this session. If there are any additional questions in the chat. Oh, I see there is a question from a member of the RPCA, Candice. She asked, is this model scalable beyond Uganda?
Which one, the foster children or the?
She just asked about the model, but I think maybe just in general, if any of the programs are scalable beyond Uganda.
I mean, the child sponsorship model is used in a lot of places. It's not, I think that's not unique to Uganda, as you see, globally, that's a lot. But I would think that foster village, I think, is the most unique thing that I've seen, that really avoiding, really trying to keep kids out of orphanages. And so, yeah, I think it could be very scalable. And if you have a community that can identify these families and support these families, but there's just, I would think there's some kinks that still need to be worked out, but yeah. Would you answer anything else? That's okay.
All right. Well, thank you all so much for joining today's GRIT seminar, and please stay tuned. And thank you again, Ernest and Becky, for joining us today. And please stay tuned for our next session. The date is to be announced. All right. Thank you all.
Thanks, everyone.
They're a little